afterwards. Okay, so welcome everyone to this webinar. I'm quite sure there will be more people joining the webinar when time passes. My name is Katrin Schiffer. I'm the head of Correlation European Harm Reduction Network and also of the Regenboog Group, which is our harm reduction service based in Amsterdam. And our network is a network which exists already since 2004, and we have 400 members across Europe, including organizational and individual members. We do a lot of work around monitoring, advocacy, capacity building. And I welcome you to this wonderful webinar, which is about harm reduction in Southeast Europe. It's nice to see many people I know, and I think it also shows how important the topic is. So again, for those who join later, be aware some
You muted yourself, Katrin.
I muted myself. Okay, these were keywords I'm saying at that point. Sorry. So the webinar is recorded, will be shared afterwards on the website together with the report. Those not me, you should be muted unless you want to speak. Please introduce yourself in the chat, and also feel free to share all kind of links or other information you want to share. And we will have Q&A sessions at one point, and if you want to say something, would be nice if you raise your hand so our chair can give you the word. So shortly before we go to the real speakers and panelists, I tell you a bit about what the report is about or what the webinar is about. So we are launching the report Beyond Numbers Harm Reduction across Southeastern Europe. And this report has been prepared together with the research by Irena Molnar, who is here and will later on present the report on behalf of Correlation. And more broadly, it has been developed within the framework of an EU-funded project. It's called Boost, and it comes to an end in December this year. And the report is about supporting community-based and community-led organizations in providing communicable disease prevention services in a comprehensive harm reduction approach. And as CERN, we have been conducting monitoring already since 2019. And what we saw is we do that in hepatitis, we do this in in harm reduction essentials, new drug trends. But to be honest, when it comes to data from Southeast Europe, this data is very fragmented and it's very, it's not sufficient. And this makes it hard for us and also for our partner organizations to actually develop tailored advocacy. And this is exactly where the Beyond Numbers report is chipping in, and it fills this gap, and it really provides lots of insights and highlights persistent barriers in access. And it also offers clear recommendations that will support us in developing future activities. We are really truly happy with the result of Irena's work, and my congratulations to this really great piece of work. It will really contribute, I think, to activities in the future. What will we do during this webinar today? So Irena will present the main findings of the report and discuss what's coming out, what are the main points. And we will afterwards have reflections of regional experts who will comment on the report on their very specific regional perspective. And afterwards, we will move into a panel discussion with wonderful panelists. So we have Rebecca MacDonald from the EUDA, Gana Dovbak from the Eurasian Harm Reduction Association, and also Milutin Milosevic from the Drug Policy Network Southeast Europe, who has a double hat today because he's also chairing this webinar and moderating. So in other words, we have a great and very knowledgeable panel, and I look very much forward to the discussion. So I'm nearly done now. I want to thank, first of all, Irena one more time for doing this wonderful work in the report, but also all the speakers and panelists and you as participants to join this meeting. I also need to tell, unfortunately, I will not be able to attend until the very end to the meeting or the webinar. I have to leave a bit earlier, but I'm sure it will be a great webinar, and I hope you have great discussions. Thanks for being here, and I give the word to Milutin.
Thank you, Catherine. Good afternoon from me also, from Belgrade. You will hear my voice is something like deep. I have a small kind of problems, health problems since yesterday evening, but I hope that you will hear me and understand me. So as Catherine already said, the first part of the webinar will be presentation by Irena Molnar, who is the key researcher who prepared the report. Irena is PhD already, yeah, or student still.
No, I'm a master, not a PhD yet.
Master, yeah. I was not thinking that maybe it is still something there. Anthropologist, researcher, and she's also chair of the European Harm Reduction Association, as far as I know, member of the Correlation Steering Committee, and she's for a long time already founder and also behind the organization Regeneration from Serbia, working mainly with young people in our country. So, Irena, please start the presentation and tell us all the results of the research.
Thank you so much, Milutin. So I'm going to share my presentation, and I hope you all can see it. Okay, so first of all, thank you so much for organizing this webinar and also for a chance to present this research in this online setting, but also I think it's important for us to discuss this. We should thank Correlation, DPNSEE, and Eurasian Harm Reduction Association for the opportunity for this research to be done, because as we heard from Catherine, and also as we know from the ground, there is a limited research in Southeast Europe, I mean, in the countries of Southeast Europe, and with a focus also on the Western Balkans, who is a big part of this region. And this research can give us a little bit more insight, in my opinion, about what happens on the ground and how things actually function in order to be able to deliver advocacy related activities. Okay, I muted Jovan. Sorry, Jovan. So in that being said, I'm going to present today the research that I did over the 6 or 7 or 8 months this year, from the spring to autumn. And this initially was an activity who I consulted Correlation and did under the hat of Correlation as a researcher, being that I'm the one knowing this region. I used to be working in DPNC. I am chair of the board of Eurasian Harm Reduction Association and as well steering committee member of Correlation. That being said, I'm involved in harm reduction and advocacy policy and research activities in this region for 15 plus years right now. And for me, it was very important to deliver something that will be usable and that will not be another report. Another report that nobody actually reads. So why this research? This research was created as it is, and it was a process of its creation because we had an idea to make a report that could actually explain the overall situation of Southeast Europe. But being that all of the countries and situations are very different, but yet very similar in our countries, it was ongoing process of how we actually will going to do this research and how the data will be presented. So harm reduction in Southeast Europe is very underfunded, and in most of the countries, in particular Western Balkan countries, is super unevenly distributed. That being said, the region, even the countries of European Union that are from the Southeast Europe region, are also very affected and also not having unevenly distributed services within the country. Just to mention that while presenting this research, the countries that we are discussing here are 11 countries that we understand as Southeast Europe. Those are the same 11 countries that are under the scope of Drug Policy Network Southeast Europe. These are Bosnia, Serbia, Montenegro, North Macedonia, Bulgaria, Romania, Slovenia, Greece, Kosovo, Albania, and Croatia. So these 11 countries that are the countries that we're discussing in this region. Following the Global Fund withdrawal that happened in most of these countries, the program are struggling to sustain services. And even though we, in the past couple of years, saw that some of the countries are going to have sustainable services, we also are witnessing closure of the services in Serbia and North Macedonia in the last year. This also make this research even more important at this present time, because we can still discuss how we can improve the situation or how we can advocate for sustainable services. So this report is capturing the service coverage, the policy context, and lived experiences in 11 countries. That being said, it is not one report. It is not another one report that just explains data in these countries, but also was trying to compare the data that exists, the services that are existing or struggling, but also having a qualitative part that was involving community-based organizations, service providers, people with living or lived experience, and also are very much important for this part. And also my aim was to build a monitoring and advocacy tool, and also something that will be used in the advocacy work of these organizations, but not only for the advocacy work of local organizations on the ground, but also that can be used of international networks such as these three that are hosting this event, but also can be used for policy. It can be used for different bodies on the local and regional, also national level. So the research was super complex, and implementation of it was going on in several stages. So I firstly did the review of existing data, not only from correlation data monitoring that is very extensive and very amazing database that was done throughout the years, but I also did evaluate the UDAS country reports, WHO reports, UNODC data, ECDC data, and national sources. Just to make it a little bit more into a context, I could understand most of the countries' context and also national reports, but also some of those languages I don't speak. For example, Bulgarian and Romanian was very hard for me, also Albanian and Kosovo reports, but the rest of the data I could also understand from national sources as well, being that I also lived in Greece where I speak the language. I did analyze this information to identify coverage gaps, strengths, and regional patterns. And my first impression after analyzing things, collecting things from 11 countries, analyzing things from 11 countries, is how big of an issue data in this region is, and how big of an issue is making a regional report without being able to compare data in all of the countries or most of the countries, being that all countries have different data sets, different reports, different years of reporting. Even in EUDA website, who is the database that we always go to when we are doing European research, even there we are witnessing that national countries who are coming into that database are old or outdated or similar things. So I had to think about how I'm going to make a report who is going to represent something that will cover 11 countries. So this was my first, let's say, how to say, not a barrier, but this was the first complexity that I had. Then after this data collection, I held 11 focus groups and interviews in 4 languages with service providers, peers, with living or lived experience. Mostly service providers were the one who were present at the focus groups, and this is, I guess, the opportunity also to thank everybody who is present here, but also to thank everybody who is not with us today, but did use time and did spend time with me evaluating situations and answering why questions, and also providing data from their countries, because this report is like this because they offered some time to sit with me and dive into data and experiences. So I think that the combination of what I did is existing data, and mostly quantitative data there is existing from the countries, but also adding qualitative parts to it is something that translated numbers into real life service access and policy implementation, and explaining how that actually is. And this is why this report is called Beyond Numbers, because what we usually have when we have big regional reports is just the data about is service existing or not existing, or how numbers of people who live with HIVs, for example, people who are using drugs or not. We don't usually go in these reports beyond that about like what that actually means. So this report has an idea to dive in a little bit about what we mean when we say there is harm reduction in a country, what we mean when we say there is existing needle and syringe program in 2 cities in Serbia, let's say, or what that actually means for people and how people can access the service beyond existing the service, and what means for them to actually have it or not have it on the in real life. So this is something that I'm not sure has been done for the Southeast Europe for sure, and I hopefully tried and succeeded into at least bringing this image or bringing this experience up front. After I did the data collection and the desk-based service, analyzed quantitative data, and did 11 focus groups and 4 interviews, we had to sit down and think about how to combine all this data into something that could be comparable within the region. So I did create a methodology from the scratch, meaning that I developed a scoring framework and qualitative design to interpret and contextualize the data. So this scoring system was informed by WHO, UNODC, and UNAIDS technical guidelines for countries to set the targets for universal access to HIV prevention, treatment, and care. So I did use the guidelines to framework the scoring system based on which we can compare all of these different but yet similar countries. And also this scoring system and the ranking that I did afterwards is not meaning that, for example, if Slovenia has 97% success, that not necessarily means that everything is perfect. It just means that in 97%, they covered the basic targets for universal access to HIV prevention, treatment, and care. So this is only the basic. Everybody that has lower scoring system means that they're not even there to cover the basic targets. So this is something that also I was discussing with peers and also with the service providers doing this research, is that we're not assessing here the quality of service as well. So we are assessing only existence and access to the services. So basically the quality of services is, and I hopefully will be, another research that is like whole other story adding to this. So I did scoring methodology to cover 4 domains: service provision, policy, epidemiology, and data and monitoring. And after I did score initially these domains, I validated results with service providers and peers for accuracy and relevance. I have to admit that I was hesitant a little bit to even do this type of a methodology, and form a framework that could be doing all of this, but after receiving super nice responses, and also after confirming with the service providers through validation that the scoring system was basically similar to what I thought it's going to be, and not really changing the scores too much, we figured out that this methodology could actually work, and that we could have some regional picture in this sense to also compare the countries, but also to do a regional advocacy. So after that, I combined the quantitative scores with the qualitative insights to show what the numbers mean in real world practice. So a little bit about the scoring structure, because when you are going to read the report and when you go through the report, I think it's important to know how I did it and what is behind all of this. So each country was accessed across 4 equally weighted domains. So each was scored 1 to 10, and maximum composite score was 40. After that, the formula extracts those 40 into 100, so we can actually see the percentage. So in services, we were evaluating the presence, coverage, accessibility of core harm reduction interventions, including OET, NSP, HIV, hepatitis C testing, overdose prevention, and prison-based provision. In policy, we were scoring legal and policy environments, integration within the public health system, financing arrangements, and the extent of the community participation in the government. In epidemiology, we were scoring availability, recency, and scope of the epidemiological indicators, including prevalence estimates, treatment coverage, and mortality data. And in data and monitoring, we evaluated the systematization of national monitoring, the existence of registers, annual reporting, overdose surveillance, and public transparency of data. So it's a complex thing to be done, but I also think it really shows overall picture of situation on the services. So as I said, those 40 in total will then present in index total of 100, and then we have 4 different countries, like purple where situation is critical, pink where situation is weak, light blue where it's moderate, and dark blue where it's strong. So all these 4 I think are showing the exact thing that I wanted to actually show, saying the country profile has a scorecard, and in that scorecard, all this data is evaluated. So limitations of this methodology is existing, and I'm not saying that it's perfect, but I also believe that this is a start of a start of monitoring that could also be community-based in essence, and also can guide us into where the biggest gaps are and where are very good. So limitations are that it could be oversimplified, so numerical scoring cannot capture the full complexity of service realities, but this is why we added the qualitative part into these reports to actually explain what these numbers mean. There is data gaps and bias, so we definitely are sure that the data relies on uneven data that is existing in the country, and this is what I said before. Even when looking at the big reports or like data collection of many different international organizations, we do have gaps, and we cannot really compare all of the countries because everybody does something different, even though and it's very complicated to actually work around this, but also perspectives that are marking or giving the scores are vary and can vary by the city or provider. So there are uneven monitoring systems, so countries differ in definitions, quality, and availability of data, which is super important, but I think that we a little bit at least overcome this. And score versus reality is what we are facing. Scores are only an entry point, and qualitative insights will provide needed nuance. So as I said, and I will repeat, this is just the start of actually seeing where we are. But after this, I expect that many other researchers will come and will be published. So it goes deeper to several different topics. So So the report outputs are several, and I'm not going to go too much into all of those, but we do have ranking system that was created based on this. We have rankings based on several domains, the 4 domains that I mentioned. We have sub-indicators in the scoring structure that I think it's nicely and clear to explain, so everybody tomorrow can use this methodology further, or use this methodology to do comparison on their local levels, or comparison of countries, or build another advocacy case for any other regional thing. So this document also has recommendations for decision makers, as well as short, medium, and long-term actionable recommendations for service providers, peers, and civil society organizations. So I didn't only do recommendations that are for the decision makers on a national level, or like decision makers on a regional or like European level, but I also did something as short, midterm, and long-term recommendations for civil society organizations that is applicable even without any major funding, already tomorrow. So in that sense, I think it offers something else. So yeah, a little bit about the ranking. You can see the ranking of the countries of Southeast Europe on a side, and its result of everything that I just explained. I'm not going to go into details country by country, because this will last for a longer time that we have for this. But I'm just going to explain a little bit about how a little overall situation. So with the countries. Ranking, countries are showing large disparities in harm reduction system and maturity. So that means that many countries are super different among themselves, being that we have Slovenia, who has most of the services or all of the services from the baseline, but for example, next to it we have Bosnia, who has barely something. Not even the Netherlands Range program for the past, let's say, 4 years. So, I mean, those are the differences that, like, doing advocacy on a regional level makes it even harder. So top performers have stable funding, diversified services, and strong community involvement, or at least some community involvement. But the lowest ranking systems show service closures, donor dependency, and fragmented provision. Ranking by domains is also being done, and in that sense I'm going to just explain a little bit about how they function. So in service provision, highest countries with the broad OST, RSP, and testing and outreach coverage, but the lowest are those who have service closures, and in that sense Serbia, Macedonia, and Bosnia are the most affected by the closures. Policy and financing environment, the strongest country are the one where harm reduction is formally recognized and fiscally supported. They have budgets and also some systems that are funding these services. But the weakest ones are the ones where harm reduction relies mostly or almost entirely on short-term donor or municipal funding that is unstable. For the epidemiology and monitoring, the leading countries are the ones with the routine testing, surveillance, and hepatitis C pathways, but the lagging countries are those with inconsistent data, low testing, and unclear hepatitis C access to treatment and care. So for specifically people who inject drugs. Community and civil society involvement, the highest ones are the ones who settings are strong, peer networks, and structured NGO government cooperation. But the lowest ones are the ones where people who use drugs' voices are excluded or not existing, and when discrimination and stigma is high, that these communities are not even present in the public debate about their own lives. A little bit about the overall results. When it comes to service availability, service closures are the ones that are most affected right now. And for me, I think that most important thing today for me was that we have representation from North Macedonia and guys from HOPS who can also a little bit maybe talk with us about how real life service provision right now functions. because they closed their services in November last year, but also what is reality for all of the region. When I say all of the region, that means also EU countries and also countries who have higher scoring, is that service provision is mostly oriented in the capitals or the largest cities, and that for example, Greece and Croatia that has developed system of, service system overall in the country have islands where services are just not available, or islands where people are just stigmatized and discriminated. So, or islands from which people have to travel to a bigger island or to a bigger city to access these services. So even though they have basic services in the mainland and the bigger islands, some of the remote islands are still have inaccessible services for people. So policy and financing environment is overall the weakest domain region-wide, and I think this will also be reality in the future. We can see from the European networks and also on the European level how policy is changing and how budgets are changing and how funding priorities are changing. And also I believe that this will be a reality for harm reduction services overall. And we are having discussions in the networks about this crisis in harm reduction for many, many years now. Sadly, this is something that Western Balkan countries are having as everyday lives for a decade now. But now discussion is also moving to EU member states, and also some of these recommendations might be useful for those countries as well. For the epidemiology and monitoring, data systems, as I said, are super inconsistent. So there is no regular IBBS research throughout these countries. When you go into the data and monitoring, and also when you go to, for example, EUDA website, you can see that each country has a different date of their IBBS research, or some of those are super outdated and some of those are not even existent for the past, I guess, 5 years. Some of those are unpublished, and also it's very questionable how some of those data is created and who operates that data as well. That being said, I'm not really sure that when you see overall the data existing from the region, I'm not really sure that we have a clear picture about the number of people who inject drugs, or number of people who are using drugs, or at least of number of people who inject drugs and have hepatitis C. For sure, we don't know. So there are many different gaps, many various gaps, very serious gaps in the system of data and monitoring overall in the countries that needs to be at least said out loud, because I refuse to believe that I have to use 2019 data of IBBS or 2019 or 14 data for some of the research that I was recently doing, because there is nothing new published. So that being said, I don't know if the countries are doing evidence-based policy making based on the data that is outdated. I know that Bulgaria did IBBS research recently, and I'm very happy that civil society was one implementing it. So this is something that could be said that is a good practice example, but I also think that more countries need to be resilient in a way, and also offer space for civil society organizations to provide the research with the communities, so we can actually have data that is consistent and data that is real. That being said, the NGOs are, and peer-related organizations are, the backbone of harm reduction organizations, and they're sustaining services also through innovation, through many different various support that is not really funded by traditional funding mechanisms, because they're not, in most of the cases, specifically on the Western Balkan, not even recognized. But also I believe that when we're talking about harm reduction in this region, resilience of civil society organizations is what is keeping these services alive still. Not really the governments, sadly, but also I believe that this is something that that we are going to be able to change. I know that we're saying this for such a long time, but I still kind of have a hope that things might change eventually. The report, aside of the overall results, has a scorecard, and the scorecards for each country is done like this. So there is the index and also the scorecard with domains and why those domains and how they're marked like that. But also there is a little comment and key gaps and enabling factors from qualitative research that are in detail explaining why they're scored like this and how they're scored eventually. So the scorecards are, I think, important because for me, when I was starting doing advocacy, it was very hard to explain to decision-making authorities or Ministry of Health about how they should read 30 pages of the research that I recently did about this and that, because none of those people wants to actually sit down and read. But I also think that this scorecard system digested information that we actually have into something that can be faster look, and they can bring the important information to the table without asking them to sit down and read dozens of documents that they will not read anyways. I remember when we did proposals for policy reform in Serbia related to cannabis, for example, Milutin remembers that we were sending dozens and dozens of documents to them, which nobody eventually read. And even if they read that, people who are deciding in our countries about what was being changed in a policy on a policy level, most of the people do not really understand drug policy at all, or it doesn't come from the field doesn't come from the field so they could understand. So this is why I decided to digest the information that I have to also be easier used on the national level as well. Last but not least, I don't even know what's the time because I don't have a clock and I don't see the time on my computer. I only see presentation.
Well, you're kind of, let's say 8 minutes longer than it should be.
Okay, I'm doing recommendations and I'm done. So what I think overall from everything that report is going to say, I think that the several things are very important to digest or also kind of take out from the recommendations. And what I strongly believe is the most important thing for the region at the moment is to find the support for national IBBS research. This is something that I believe, if we don't, and I was discussing about this with Ghana for so many months right now, is that reality is that we do not have data on people who use drugs. And we do not have data on people who inject drugs and living with HIV or hepatitis C. If we don't do this research, we don't test, and we don't do it with the support of community members or community-based organizations or people with living and lived experience, we know nothing. And based on that, we cannot really advocate for services, or we cannot really advocate for strong harm reduction, for strong harm reduction in our countries. That being said, it's hard for me to believe that we are back 20 years ago where we didn't have the data and suddenly then we had the data, and now we're just like, I feel that if countries are not doing this type of a research or do not give funding for this type of a research, we're just turning a blind eye to a situation that happens and just like trying not to see that we have an issue that we need to figure out what we're doing with it. So if we don't have data, we're not going to be able to actually build anything that will be evidence-based. And this is why I think that most of the services are also closing. And the second thing that I also think that it's the key bone of everything that we need to do is to do capacity building and strengthen the community-based monitoring, and also to invest in community and peer leadership. I know that our region is known for very patriarchal, very strict, and very strong opinionated about people who are using drugs, let's say. I'm going to say it like that. But I also think that we need to reduce stigma and discrimination in all of the systems. And I also think that if we work on that, we're going to be able to go beyond where we are right now. Why? How to say? I mean, I often believe that we are now in the point where we were when I started doing harm reduction and when I started doing research and drug policy reform activities, we were much in front of where we are right now. This is what I wanted to say. I think that situation is deteriorating. Is this said correctly? And I also, I mean, I don't want to believe that this is the road that we're taking. So I wish to see governments and also civil society organizations and also local governments. I want to see and I want to believe that they wish to invest in the community in peer leadership and also in reduction of stigma and discrimination in the systems, because most of the countries and most of the organizations and service providers are, I mean, definite about one thing is that people who use drugs are not really active and not really visible because this is where they're discriminated the most. So if you go to a service or to healthcare clinic to be offered the service that you need and to be discriminated there, I think that we pushed with the system as it is. Like now, we push people who use drugs into the shadows, and I really believe that the key for changing and success in this is to bring them up front. I don't think that I have anything else to say, and thank you, and sorry for being longer. I can talk hours about the situation, and I'm very passionate about it because this is something that I was and I am doing still for many, many years, and I also am very passionate about the change, and I want to thank everybody for this opportunity as well. I'm going to stop sharing my screen.
Thank you, Irena. We all know you as a passionate person and understand your approach to it. Just before we go to the next segment where we will have our colleagues from countries discussing and contributing to the report, I would just say that I made two remarks during your presentation. One was the question from Andreas from Cyprus asking why it actually proposing that it would be good to have also data from Cyprus. And this is the old story about what are the boundaries of the region, with people also thinking that Cyprus, especially because of close relations with Greece and Turkey also, if you look at the whole island. Then Moldova, which has very close relations with Romania, and Turkey definitely would be also part of this Southeast Europe grouping. At the moment, the situation is as such, and we have these 11 countries, but I think that if what Irena proposed, we maybe agree on some approaches and levels of collecting data, then it will be easy to add countries also around, especially because what we also know is that borders cannot stop problems and cannot kind of close, kind of isolate countries when you talk about drug issue or HIV prevention or whatever else. And the second point is, which I saw, is that Romania was classified as weak, and it has 53.75, which is above 50. So maybe that's a small thing which the presentation, maybe just that part of that slide is not correct.
I'm going to check that. Thank you.
Yeah. Okay. Yeah. These two things. So, okay, we go now into as I said, into the next section where we have our colleagues from Slovenia, Bulgaria, and North Macedonia commenting and adding to what we heard from Irena. The questions which we prepared there are three questions. So, what is your reflection on the results of the regional report as general, and what findings describing the situation in your and neighboring countries worry you the most? And the second question, I would say, would be what recommendations you would propose to be prioritized and to be kind of helping us to be better responding to the needs of the community of people who use drugs in your country. So I will first invite, if we go north-south, and also if we go in the ranking from top to down, then we will ask the first speaker, which will be Borut Bach, the director of Stigma Association from Slovenia, to take the floor and comment from his perspective. Borut, please.
Yes, thank you. Hello, everyone. Well, I must say that I'm a bit sad of hearing the results, especially for other countries, maybe not for Slovenia. I think that given this situation in many countries where some harm reduction programs, including needle exchange projects, are going to be closed or maybe underfinanced, I think it's not the good situation. So probably the discussion on how to provide more harm reduction programs in the region would be perfect for this place, or maybe for some international networks that are working in this area. So, as I said, based on what I have heard in these countries, I would say that situation is quite in order in Slovenia. We get finances from local governments, from state fundings. We have quite good European Union support. So from that point of view, I believe that existing programs in Slovenia will not be closed in near future, which is okay, probably, but you never know. Maybe some history from Slovenia. We had some issues with financing at the beginning of the 90s. I'm not aware how much of our harm reduction history you're familiar with, but in the beginning of the 90s, we have very similar situation as some of the countries you have now, so 20, 25 years later. At that time, we were financed mostly from Open Society Institute and the Linda Smith Center from New York. Some fundings come from WHO. But very soon, somewhere in the middle of the 90s, Slovenia was treated like well developed by the criteria set by these financiers. And very soon in the 90s, our country was forced to finance these programs. And fortunately, they did it. So we have a needle exchange project and a substitution treatment project that started at the beginning of the 90s or in the middle of the 90s. There were sometimes, maybe for a few months, when we didn't have enough of syringes and needles for users. But fortunately, HIV and hepatitis C infections did not develop in big numbers at that time, such as in Greece, as I know, in 2012, or maybe in Romania in the last years. So over the time, let's say now, this finances is, as I mentioned, okay. State allocated enough funds for basic programs to work. So again, I believe that we will not shut them down. Maybe regarding this research in Slovenia, we have one saying that goes something like that every research reveals something but hides a lot more. So from my perspective as an NGO person and from the perspective of our users, I'm sure that we are not as good as this research showed. So I think we had 97% of everything. Well, it's true. If there were questions like, do we have naloxone to take home in Slovenia? Yes, we do, on paper. We do have drug consumption rooms on paper since 2013. We have it in our national plans. But it took us 10 or 11 years to open the first drug consumption room that was opened last year in Nova Gorica. This is in very small town very close to Italian border, and we still do not have drug consumption room in other cities that are bigger than Nova Gorica, like in Ljubljana, which is the capital with the most problematic drug use seen also on the streets. We still didn't succeed to open the DCR. The same is, let's say, with this project like naloxone to take home. We have it on paper, and it has to be like that naloxone should be accessible to all people who are involved in substitution treatment centers. We have 20 substitution treatment centers in Slovenia. In 2 of them, everyone who is entering the substitution treatment center will receive naloxone to take home. But let's say the biggest substitution treatment center in Ljubljana, where about 700 drug users come in daily, they maybe gave this naloxone to take home only to 10 or 20 persons. So we have it on paper, we have it on all sorts of data collections from EUDA or whatever these networks exist. But if you ask users or us as an NGO, we are not satisfied with the number of distributed naloxone. Maybe this is just the beginning, and I'll answer some questions later.
Thank you, Borut. And thank you also for being short and very concrete. You mentioned the thing that the classification of countries, which put some of our countries into kind of middle level, even high level income country, while then it's not to be supported by some international organizations. I think maybe the good case of it is probably Bulgaria, which is EU member country. Hopefully everything will work well. But we know that for a period of time, they were complete also, like it's happening in Bosnia now, the services were closed and there was a big struggle to recover them. So now Bulgaria is, as we saw, in the kind of safe situation by the classification which Irena did. But I'm not sure if Julia would agree with it. Julia, can you please contribute?
Hello, everybody. Thank you, Milutin. No, I'm not agree with you. The situation in Bulgaria is very good at the moment, and I'm very proud of this because we put a lot of efforts. But regarding the sustainability, it is very serious problems here because there is only one working organization. It's our organization in the whole country. So if tomorrow we have to close somehow our organization, everything will cost again. So maybe it is important to mention how it happened in Bulgaria. Maybe part of you knows that a few years ago there were nothing in Bulgaria. I mean, nothing at all after the Global Fund withdrawal in 2017. Absolutely all harm reduction organization closed. And that was the moment when we opened our pink. So to try to save something, at least something for the people who use drugs in Sofia. And we put a lot of very serious efforts to save this place and to open another one, and etc. etc. So it's important to mention that there is no specific harm reduction funding in Bulgaria. There is different sources we are using to ensure some kind of funds for our work. We are using a lot of, we are working very well with the Sofia municipality and with the social system. In Bulgaria, it works very well. The Ministry of Health still doesn't recognize the issues of people who use drugs here, but the Ministry of Social Affairs recognized it. So at the moment, we are working mainly under the funding of the Ministry of Social System, which is very, very pity because at the moment we have, I can say, serious problem with fentanyl use, and we have a lot of overdoses at the moment, and we have no naloxone. I mean, we have no naloxone for our staff also. Yesterday, my colleagues in Plovdiv used that to sprays. So today we have no now some for any kind of we have no chance to react. So it is maybe it is important to mention that yes, there are really serious results after all these years we are working. At the beginning, we've opened the pin house in Sofia, which were funded mainly by crowdfunding during the first 2-3 years of the existence of this facility. And after we had a chance to ensure it was a precedent for the country, the Ministry of Social Affairs to recognize the issues of people who use drugs. After we made that precedent, this year we opened the second drop-in center in Plovdiv. This is the second major city in Bulgaria. And my colleagues there works a full day for the beginning of September, so it is very, very new. Still, we have no the municipality funding for this facility because we need more time. We have provinces, but still the money are not here. And of course, it's connected with the annual budget of the country. So yeah, I really hope that we will ensure some funding for this facility also. So at the moment, the drop-in center in Plovdiv is funded mainly again mainly by crowdfunding and by one international project, which is connected to much more to outreach work, not to that kind of a drop-in center, but still it is how we have a chance to work. Maybe this is the most important thing I want to add, that even if there is one strong organization who tries to make a lot of efforts and who built a good political connections, etc., if it is only one organization, it isn't guaranteed sustainability in the country. Because unfortunately in Bulgaria it is not a national priority. So yeah, I'm here for your questions, of course, but yeah, it is
Thank
not
you, Julia.
organized.
Julia is probably so shy not to mention that she was declared the champion of entrepreneurship in the social area in Bulgaria a year ago, something like that, because of the crowdfunding campaign they did. And it's really one of the good examples of thinking out of box and trying to solve the problem with your own hands, not waiting for the others to solve it for you. Congratulations again, Julia.
So, thank you very much.
Well, if we would ask these kind of questions to Macedonia, North Macedonia 2 years ago, then probably the response will be similar to not exactly Slovenia, but at least to Bulgaria at the current point. But then some things happened recently which really changed completely the situation, and I know that the country is now experiencing problems. So, I mean, our colleagues over there working. So Bogdan, can you please tell us more about?
Well, yes, of course. I first would you like to take the opportunity to speak here? The regional report is important because it finally connects a number with real life. What I appreciate most is the transparency. It shows clearly where a system function and where they fall. And it does so through the voices of civil society, peers, and communities. For me, the report confirms something we all see on the ground. Harm reduction in our region survives thanks to NGOs, outreach workers, and people with lived experience, not thanks to the stable state systems. The scorecard approach reveals the regional gap very clearly. Countries like Slovenia and Greece have embedded harm reduction into public health and social protection, while the rest of the region is stuck in cycle of short-term fundings and political neglect. The report also highlights issues we rarely see in official documents. The lack of gender sensitivity services, the invisibility of rural communities, and the structural violence people face in prison, hospital, and social institution. For me, this mix of quantitative and qualitative insights makes the report extremely valuable. One of the most worrying findings is what happened to harm reduction services after the withdrawal global fund. When the Global Fund ended support in our region, many services were suddenly left to survive day to day without predictable financing or government replacement. We see the consequences across the region. In Bosnia and Herzegovina, NPS disappeared completely. In Serbia and North Macedonia, coverage has been drastically reduced. In my country, the change was dramatic. Before the Global Fund left, North Macedonia had 14 needle and syringes programs nationwide, 4 of them run by HOPS. Today, the only things that remain in HOPS outreach team, and even that team is uncertainly for next year. We simply do not know if it will survive. This is not just a funding issue. It means real harm, more unsafe injection, higher risk of hepatitis C and HIV, more overdoses, more people completely disconnected from help, outreach teams burning out because the need grows, but researchers shrink. Another major concern is the invisibility of key groups. Women who use drugs, young people in nightlife, and people from rural areas remain almost completely outside for service planning. There are almost no gender-sensitive services. Even though women face stronger stigma, higher levels of violence, and greater barriers to treatment. Young people in nightlife environments also have a unique risk, yet services are not designed with them in mind. This gap creates a situation where the people who need support the most are the ones least likely to receive it. Based on the needs in North Macedonia and the region, I believe the following recommendation must be prioritized. My first recommendation will be restore and expand harm reduction coverage. We need stable long-term funding for needle and syringes program, outreach and community services. Without basic coverage, everything else becomes symbolic. Governments must treat NSPs and outreach as essential health services, not optional NGO projects. My second recommendation will be integrate gender sensitives and youth specific services. We need a safe space for women who use drugs, support for survivors of violence, counseling without stigma, and real inclusion and policy design. For youth, especially those active in nightlife, we need education, early intervention, and honest drug information, not fear-based messaging. My third recommendation will be introduce evidence-based intervention that are still missing. They include naloxone distribution, which in Macedonia is still accessible only through toxicology, overdose prevention and drug checking services, which is not available in the country in Macedonia. These interventions save lives and give people accurate information about what they consume. Strengthening community-led monitoring will be my fourth recommendation. People who use drugs, outreach workers, and civil society see realities that official statistics often miss. Their data must shape policy and funding priorities. My fifth recommendation and last will be ensure continuity and care in prison and rural areas. People in prisons and those living outside Skopje and other large urban centers cannot remain invisible in policy planning. Opioid against therapy must be available continuously, not only for those who were already on treatment before entering prison, but also for individuals who need to start treatment while inside. Likewise, services cannot be concentrated only in capital cities. Rural communities deserve the same access to harm reduction, treatment, counseling, and outreach as anyone else. Without this, we maintain a system where geography decides who receives care and who is left without support. And my final message will be, if we want real change in our region, we must stop treating harm reduction as an emergency response and start treating it as essential public health infrastructure. The evidence is clear, the needs are visible, and the solution already exists. We only need the political will and stable funding to implement them. Thank you.
Thank you, Bogdan. Bogdan also did the homework on presenting recommendations. Just before we enter into the second part, where we will discuss with Rebecca and Ghana about what can we do about this in the future, I just maybe could just repeat what, in a way, which I noted what Irena said, more data, especially IBBS would be a recommendation. Community involvement also and strengthening, also supported by Bogdan. Reducing stigma and discrimination, restoring and supporting harm reduction services, specific services, gender, youth, prison, evidence-based interventions like naloxone. Just to say that when we had a discussion in Serbia with authorities about it, we learned that one naloxone capsule costs about something like 1.7 euros and save lives. And again, still they're missing, like we heard in Bulgaria, or can be only distributed through emergency services. And also, yes, these are some of the recommendations. Borut, Julia, maybe you have something else to add?
Regarding the recommendation, do you mean?
Yes.
Yes, of course. I'm agree with Bogdan and also with Irena. Of course, I mean this is the main things we need to want. But the biggest question is how we can achieve them. I mean this is the main problem because I think that I have a right to say that the politicians doesn't care about these problems. So even the data we have, the data, Irena, our IBBS is for only for Sofia, unfortunately, not for the country. But our data is awful, and no one cares about it. No one cares that we have 17.1% HIV positive people among the group of people who inject drugs, which is huge. We never thought that it's possible to happen here. So unfortunately, in that situation, my experience said that we need to deal by ourselves. I cannot rely on politicians, unfortunately. So yeah, and of course we need all these things. Of course, we need to have a chance to work with women. Of course, we need to have a chance to work with people with comorbid people, let's say, because we have a lot of them here. Of course, we need to have shelters for people who use drugs, especially for people who use drugs, because most of people we are working with are homeless, so it is a huge problem for us here. And all these things are very, very important and can change the situation in very good position. But unfortunately, I cannot recognize any interesting institution again, around that. So sorry to say that.
Thank you, Julia. I guess Borut, yes, or okay? Okay, yes, Borut, please. And Irena will also add something.
Well, I do not have, solution, but maybe if you are thinking about, of course, what we can do to help programs develop or to remain stable or stably financed in this region. A few years ago, maybe 10 years ago, we have some ideas to send the information to responsible persons in these countries. I remember that we sent a lot of emails, as I said, maybe 10, 15 years ago to Romanian Ministry of Health when they were thinking about closing the needle exchange programs. But maybe I'm a little bit naive, or as I remember, nothing really happened in that way. So we must think in some other way. I was discussing a few days ago about the situation that was presented today by Irena, that some countries do not have needle exchange programs. I was discussing this with a person from Ministry of Health, who is going from Slovenian Ministry of Health, who is also a member at the WHO in Vienna. And she didn't know about the situation, which is for me pretty sad. So that's why I get the idea, and we are trying to do it with Irena next week or in 2 weeks. She will represent this research that was represented today at some Slovenian conference that will be provided by Faculty of Social Work. And there will be some representatives of some ministries in Slovenia, from Ministry of Health, Ministry of Social Affairs and Labor. Maybe this is the way to do it, to present what is the situation. That is, as I see it, it's not clear to the people who are working at the ministries or in the international level of the European Union. I'm not sure that they're aware of this situation. So maybe this should be one of the steps to represent the very sad situation from this region.
Thank you. Thank you, Borut. And Irena, yes?
Yeah, I just wanted to second what Julia and also now what Borut said. I want to second what Julia said about how decision makers do not really care. And how this is our reality, because we see how funding landscape is going to change, and there is us as a citizens and civil society organizations are now at this moment super weak in what we can actually do to affect or even try to change what we see is going to happen. And we see that this road is happening for quite a while ago, and yet we're unable to, how to say, penetrate the system of decision making in our favor, let's say. So I also, when I was drafting the recommendations, I had, you know, that feeling when you wish to recommend something, but in reality, you know that this is just like our good wishes, but not really reality that we can say to decision makers, yes, we would like to have restore harm reduction services. What that even means? Like, restoring harm reduction services means that we rebuild our harm reduction systems back where they were in 2014. So that means huge amount of money, huge amount of people, huge amount of the organization. That means so many different things that just restoring harm reduction services is just like wish to the Santa Claus, in my opinion. So I kind of I restrained myself in saying those type of the vague things which I see that are like impossible to happen right now, even though we all know that this is something we are aiming to and we wish to happen, but also having in mind the contextual change, political change, and instability, not only in the region, but globally. Saying those things like something very general is something that I didn't want to do, but yet I also did recommend, and I also did make small recommendations toward governments and also civil society organizations who are, let's say, smaller, who are something that does, who are the actions who don't really depend on if government is going to recognize our service or not. Because, for example, if I waited in regeneration to receive funding from the government or any other funder, we would be closed in 2015, I think. But instead, we didn't wait and we somehow reformed services. Also, what Julia says, this means that civil society organizations are sacrificing their lives, their private lives, their selves. You choose to volunteer, you choose to you choose to take burden on yourselves in order to do something that you believe in. Let's put it like that. And this is for us was a personal choice of what we can do from what we have. And I also know that this is reality now for correlation. This is now will be reality for EHRA. This is long-term reality for DPNSEE. And I'm just trying to think about like what we can do beyond this in the current context and in current atmosphere that is beyond what we were doing so far. Because I feel sometimes that we failed in doing things as we thought, even though it was not our fault that the political situation and the strategies and wishes of our national or European or whatever else government are changing. So political life is unstable in the world and in Europe, and this affects us as well. So how we navigate now this space is something that really scares me even to think, but also recommending things is very,
yes,
how to say, not really happy place to say.
Yes, and that's why we have two persons which have a little bit wider look than most of us do. Rebecca, who is a scientific analyst on health in the European Union Drug Agency, Drug Use, Harm and Addiction Behavior Sector, and Gana Doba, who is the director of EHRA, but also chair of the European Union Civil Society Forum on Drugs, the expert group of the civil society advising EU. So let me then ask Rebecca if she can first tell us about how they see us in the region and how do they have any perspective? Does their perspective agrees with what we are talking about? And also, are there any plans? That's what we are maybe looking now at the moment. That I think we are closing now IPA 8 project, and hopefully we will get IPA 9 in the next years. And what are the plans of EUDA for this? I have to say that we from the forum started negotiating with EUDA at the time, European EMCDDA in April last year, and we still don't have a clear plan about how EUDA and civil society will work, but we know that EUDA has much more on their agenda on civil society for the current situation. Rebecca, please.
Thank you, Milutin, for inviting us on behalf of EUDA. We're very happy to be here. And of course, congratulations to Irena and the team for the report, which we're eager to get our hands on as soon as it gets published. In terms of how we view the region, well, of course, as part of our annual coverage, as you know, we report data on 5 areas of harm reduction in the European Drug Report. I'll quickly just since in the interest of time, I'll just pop the link into the chat. So if some of the room want to read more on it. Very briefly, of course, in member states, we have widespread harm reduction and some uneven coverage of interventions. But of course, we see disparities and challenges in the region. And as we know, NSP coverage is going down, which is a huge problem. I think Greece actually is sort of the notable exception here, which manages to surpass the WHO targets in terms of coverage for NSP as well as OAT. And we're concerned about the cuts in terms of access for people who inject drugs in particular, and also the disparities of access for OAT, especially in rural areas and disenfranchised groups. Also, when we look at the European map in terms of take-home naloxone access, all of this has been mentioned before, we see a real divide. Thankfully, now have a pilot in Croatia and I think a new regulation in Greece as of the summer. But in the Western Balkans and Bulgaria, Romania, Hungary, no take-home naloxone is available. At times, cost is reported to be a barrier. Quite frankly, it doesn't have to be the expensive nasal spray. You mentioned you mentioned earlier that in discussions in Serbia that the cost of the ampules was reported to be, I think you mentioned $1. In fact, UNODC WHO had a project quite successfully in Central Asia and Ukraine, where they managed to build take-home naloxone kits with civil society organizations. And the kits contained 2 ampules with clean needles, and the cost was $1 a piece, and the estimated number of lives saved were 400. So there's a real area for impact, provided there is political will. Unfortunately, from the UDA side, we cannot fund equipment as such, which is a real barrier to our work. Having said that, thanks to the new mandate as of last year, we are fundamentally committed to working together closer with civil society. And we also have a new international cooperation framework as of this summer, which seeks to formalize the collaboration with civil society. And for the IPA project, which covers the Western Balkans, this is very much in what we're trying to achieve. We have Anna Peterfi here also in the room who's joining me, and building onto your report, the correlation report, boost report. We're wanting to get a better sense of the context around the numbers that are reported to us every year. So we're just about to embark on a mapping of harm reduction services in the Western Balkans to understand where the gaps are, the areas for needs moving forward, so that we can include this in our plans for the next iteration of the IPA project. What we can provide from the UDA side is capacity building. Just here's some examples. In May, UDA organized a Retox Academy training in Croatia on drug checking. In October, we were very kindly hosted by the Slovenian National Focal Point to organize a study visit in Ljubljana around to establish early warning systems, and with focus also on the integration of drug checking in this context. And also, as part of sort of wider UDA activities, we have the Eurasian network of emergency hospitals that report an overdose admission. So this is a way for us to get better data on more recent drug trends. So we're keen to monitor that. And for just a little advertisement for the harm reduction mapping that we're about to start, I'll plug in our email address into the chat. Very keen to hear from everybody in the room so that we can remain connected. Thank you again.
Thank you, Rebecca. It was very efficient. Also, for the time constraint, I just I invite Ghana to speak immediately after you. Ghana, we worked together in the Civil Society Forum on some recent activities, especially on creating the new European Union drug strategy, which will be, I think it's already done, and it will be promoted, as we know, something like on the 3rd or 4th of December. And also Ghana and I were working together very much on the accession process for the 6 countries and territories of the Western Balkans. And here I think, have also very interesting development. With last couple of weeks, we heard that there is a kind of a big impulse for accelerating the process of EU accession. Would you please, Ghana, also add to something more to what I said and to what you heard from all the others? Yes.
Thank you very much, Milutin, and actually thank you, Irena, and all team for preparing the report and highlighting this important region in the map of challenging harm reduction in Europe. And actually, I wanted to highlight that yes, we will definitely share the data of this report with the all possible European Commission of authorities, and specifically with those who are responsible for enlargement process, to highlight the necessity, and thanks to our activities together with Milutin and core group of Civil Society Forum on Drugs, we achieved the possibility to present some of this, to highlight these challenges to the European Commission DG INEST. And I hope that we will have some process, like to at least to start, like to not to start, to reinforce opportunities to use the enlargement process to kick off the attention of the governments in the candidate countries to ensuring access to harm reduction, and not only harm reduction, but actually all health services for people who use drugs. And that's exactly the challenge we have on the European level now, because even if the strategy will contain the proper words about the health and human rights and civil society participation and even harm reduction, which we promised that it will contain, but the key problem is implementing. And as we hear with the naloxone, it's just ridiculous to hear after 30 years of active implementing of harm reduction that majority of countries in Europe lacking the basic tool, which is very, very cheap, which is very easy to access, to administer. It's not innovation, it's just the basics. And we still don't have it, and not only in Southeast Europe, but also in Poland and in a lot of European countries. That's why in Civil Society Forum on Drugs, we are trying to highlight this enlargement process as still possible way to pressure on governments to have harm reduction and health response to the drug problems embedded in their policy and budgets. And here we need to have coordinated the European Commission together with EUDA effort to be consistent, not only on observatory, but also on drug observatory, not only on early warning system, because that's all about monitoring, but also on health response. And that's very important part of the story. And here Civil Society Forum on Drugs as coordinated effort of everybody is important, and the only platform we could use for civil society engagement. And I will share the report on shrinking civic space because that's the context we are all in, and all this populist politicians making things even worse than it was. And there are a lot of initiatives in the region speaking about the worsening war on drugs, which will create more barriers for harm reduction and health response in the future. So we, as a coordinated civil society forum on drugs, where we are working together with the International Drug Policy Consortium, with correlation with the DPNSEE as a regional network on drug policy, and us as the Eurasian Harm Reduction Association, we don't have a lot of hopes, but we need to keep going, because if we will not, then we will lose all our capacity in the region to be able to continue serving our people. And thank you very much for this important effort on analysis, because having these links and having this information to show European Commission, it's important. Thank you.
Thank you, Gana. Yeah, we can open the floor if someone else would like to contribute, even those who have been panelists, but also the participants. I think we heard a lot, but still, I'm quite sure that, like Irena said, each of us will maybe now speak for at least half an hour and tell some really very important things, But let's see if there is something which is really important, which you maybe think should be added to the discussion. I see that there was a note from Julia. Okay. Thank you.
Yeah, I just asked our colleagues if they have any contacts of the distributors of naloxone, because we need to buy some naloxone at the moment. It's not possible.
Thank you. It's very practical and very useful. Yes, I think. Well, I think maybe then we are about the time to close, if there is no more things. Thank you all. I think it was very useful and interesting. I mean, we feel a lot of, I wouldn't say anger, but we feel a lot of kind of, probably I can call it kind of frustration for being so committed. And as many of you said, so much really keeping the fire on without so many support. But as Gana said just at the end, we still need to do it. And I hope that we will continue like that, and hope that our efforts, which we are investing into explaining the others and changing their political will give fruit in the near future, not hopefully very long. Okay, thank you all. And hopefully we'll see you again. Just to say that on the 4th of December, we will have a webinar on decriminalization. It's one as a kind of advocacy effort, also coming out of the BOOST projects, which we are about to close very soon in the next month. So please follow us and join us also next Thursday if you are available. Thank you very much. We are about to close now. Bye-bye all.
Thank you, Milutin. Bye, everybody. Thank you.
Bye-bye.
Thank you.